Today, let's talk about COPD and asthma. By the end of this video, you'll be able to distinguish these two conditions instantly, both on exams and at the bedside. Both COPD and asthma are classified as obstructive lung diseases, but they are very often confused. Many people have only a vague mental picture of these conditions, so today I want to make the differences clear, simple, and practical, something you can actually use in clinical setting as well as in examinations. First, let's start with what they have in common. COPD and asthma are both obstructive disease. On spirometry, this means that the FEV1 to FVC ratio is reduced, typically below 70%. The forced vital capacity itself may be normal or mildly reduced, while FEV1 is decreased. Both diseases fall into the same categories. However, despite this shared classification, their underlying mechanisms are completely different. Let's talk about COPD first. COPD is mainly caused by long-term exposure to cigarette smoke. Smoking damages the lungs through two major mechanisms. The first mechanism is chronic airway inflammation. The bronchi and bronchioles are persistently inflamed, which causes the airway walls to become thickened and narrow. As a result, airflow resistance increases, especially during expiration. The second mechanism is alveolar destruction, which we call emphysema. In this process, the walls or alveoli are gradually destroyed. This leads to a loss of elastic recoil, meaning the lungs can no longer spring back effectively during exhalation. The alveoli become enlarged, floppy, and inefficient for gas exchange. Now let's think about what happens physiologically. In a normal lung, air flows in smoothly, oxygen enters the bloodstream efficiently, and carbon dioxide is easily removed from the body. In COPD, however, air can enter the lung, but it cannot leave efficiently during expiration. The damaged airways collapse, trapping air inside the lung. This leads to hyperinflation and an increase in residual volume. Because carbon dioxide cannot be expelled properly, CO2 retention occurs, and oxygenation gradually becomes impaired. COPD also causes ventilation-perfusion mismatch. Ventilation is reduced relative to perfusion in many areas of the lung, which makes oxygen transfer inefficient. As a result, arterial oxygen levels decrease and the alveolar arterial oxygen gradient increases. In early COPD, oxygen levels may still be relatively preserved, but as the disease progresses, chronic hypoxia becomes evident. Overall, COPD is a progressive and largely irreversible disease. The inflammation is predominantly neutrophil-driven. Emphysema and air trapping are characteristic features. Although bronchodilator and oxygen therapy can improve the symptoms, they cannot reverse the structural destruction of the alveoli. Now, let's move on to asthma. Asthma is fundamentally a disease of the airway rather than alveoli. The core problem lies in reversible airway narrowing. Asthma attacks are triggered by factors such as allergen, cold air, exercise, or respiratory infection, and so on. These triggers activate type 2 or eosinophilic inflammation within the ears. This leads to construction of bronchial smooth muscle, airway wall edema, and increased mucus production. As a result, the airways suddenly become narrow and patients develop symptoms such as wheezing, cough, and shortness of breath. Importantly, in asthma, the alveolar structure itself remains intact. There is no emphysematous destruction like we see in COPD. Asthma is therefore characterized by reversible airway obstruction, typically defined as a significant improvement in FEV after bronchodilator use. Eosinophil dominates the inflammation process, and patients usually respond very well to bronchodilators and inhaled corticosteroids. Symptoms tend to fluctuate rather than progressing steadily. One useful clue in asthma is fractional inhaled nitric oxide, or FeNO. Many asthma patients show elevated FeNO levels, reflecting underlying eosinophilic airway inflammation. While FeNO is not a diagnostic test on itself, it can be a useful supportive tool, especially when asthma is suspected. In contrast, FeNO levels in COPD are usually normal or low. Now let's compare COPD and asthma side by side. In COPD, the main pathology involves both alveolar destruction and chronic airway inflammation, whereas asthma is primarily a disease of airway constriction. Inflammation in COPD is dominated by neutrophils, with asthma is driven mainly by eosinophils and type 2 inflammation. Airflow obstruction in COPD is poorly reversible. Hyperinflation is common in COPD, but rare in asthma. Ventilation-perfusion mismatch is significant in COPD and only mild and reversible in asthma. FeNO is usually normal or low in COPD, but often increased in asthma. Finally, bronchodilators have a limited effect in COPD, but are highly effective in asthma. It is also important to note that some patients show features of both diseases. This condition is sometimes referred to as asthma-COPD overlap. In such case, clinical history, spirometry, biomarkers such as FeNO, and response to treatment all help guide diagnosis and management. To summarize, COPD is essentially a disease of destruction, while asthma is a disease of constriction. Although they share the same obstructive classification, their mechanisms are fundamentally different. Understanding this distinction makes both diagnosis and treatment much clearer. See you in the next video.